My name is Professor Jennifer Knight Madden, and I am a pediatric pulmonologist. That means a specialist for lung problems in children. One of the things that I do is to look after children who have asthma. Asthma is a chronic disease of the airways, the tiny tubes inside the lungs. When children have asthma, these tubes are inflamed. They get easily triggered, and that causes cough, wheeze, shortness of breath, and chest tightness. Today, we're going to speak about the use of metered dose inhalers. We call them puffs in Jamaica. You would be very familiar with these devices if you have asthma. They can be used to control the asthma so that you don't have any symptoms, or if your symptoms break through, to treat that attack to get you better. Now, today we're speaking specifically about a device called a spacer, which when used along with your metered dose inhaler will make sure that the medication gets all the way down into the small airways where it can do the most work to get you better. Okay, so now we're going to actually demonstrate that spacer. I'm here with Amelia, a very bright girl who's going to help. Hi, Amelia.
Hi, Professor. Hi, everyone.
Great. So here's a spacer. Now, it may come in a container like this. It may come apart, right? So that you can clean it. But when you're ready, you're going to put it together and you're all set. It has a mouthpiece that's protected by a cap, so you're going to just whip that off. We have the Flixotide, which she takes every day to prevent asthma symptoms. And then there's the Ventolin, which if she's having symptoms now, something has broken through, then she uses her Ventolin. What's the first thing we're going to do when we're going to use our spacer? We're going to make sure that our metered dose inhaler is not expired if we haven't used it for a while. So you take it out and you look at the date to make sure that it's still good. We also need to make sure that there's actually medicine in it, because it will shake and spray long after the medicine is finished. So some metered dose inhalers come with a counter, but if they don't, ask your doctor or pharmacist to tell you how to know when it's empty. So now we're going to go through how you use it. This also has a mouthpiece with a cap, so you have to take it off. Amelia, do you know where this would go? Perfect. Perfect. So now, what we're going to do, shake it, insert it. Now remember, you have to sit up straight, have your head up a little, and then when we're putting this in your mouth, you get a nice seal around the mouthpiece. Then you puff, the medicine comes into the spacer, and you breathe in and out 7 to 10 times. Breathing in and out. Now those breaths don't have to be deep, they don't have to be slow or fast. The beauty of doing it 7 times is that most of the medication will end up in the lung instead of at the back of the throat. And then the parents will be watching that tummy. 1, 2, 3, 4, 5, 6, 7. There we go. So there we go. So the beauty of doing 7 breaths is it doesn't matter if they're slow, fast, deep. As long as you do 7 to 10 breaths, most of the medication is in the child's lungs rather than being at the back of the throat. Now, if your child is younger and won't always breathe in and out through their mouth, we use a spacer with a mask. because once you have that mask having the seal over the nose and the mouth, it doesn't matter whether they breathe through their nose or their mouth, they're still going to get the medication. But what's important is that you get the right size mask. So that's how you use your spacer. And remember, you can watch this video as many times as you want until you're sure you've got it right. And the good news is that your inhalers and the spacer are all available through the National Health Fund. So ask your doctor, your nurse, your pharmacist to give you more information about how you can access them.
Hi, I'm Dr. Terry Baker, pulmonologist and internist and the Senior Medical Officer of the National Chest Hospital. Do you know that over 330 million persons worldwide have asthma, and the numbers are increasing? Here in Jamaica, approximately 11.2% of adults live with asthma daily. Asthma is a chronic condition. Once diagnosed, you always have asthma. However, it can be controlled, and some persons may not have symptoms for years. Poorly controlled asthma makes you feel ill. Your chest feels tight. You cannot breathe. You do not have the energy to do the things you need to do. So today, on World Asthma Day, if you have asthma, be educated, be empowered, and let's take control. If you have asthma, engage with your healthcare physician. Find out about your asthma. Take your medication as prescribed, know your triggers, and try to avoid them as much as is possible. Sign up with the NHF for subsidies on asthma medication, on spacers, and on masks and other respiratory devices. Let's unite for asthma education. Together, we can breathe easier.
Hello, my name is Professor Jennifer Knight Madden, and I am a pediatric pulmonologist. That means a specialist for lung problems in children. One of the things that I do is to look after children who have asthma. Asthma is a chronic disease of the airways, the tiny tubes inside the lungs. When children have asthma, these tubes are inflamed. They get easily triggered, and that causes cough, wheeze, shortness of breath, and chest tightness. Today, we're going to speak about the use of metered-dose inhalers. We call them puffs in Jamaica. You would be very familiar with these devices if you have asthma. They can be used to control the asthma so that you don't have any symptoms, or if your symptoms break through, to treat that attack to get you better. Now, today we're speaking specifically about a device called a spacer, which when used along with your metered-dose inhaler will make sure that the medication gets all the way down into the small airways where it can do the most work to get you better. Okay, so now we're going to actually demonstrate that spacer. I'm here with Amelia, a very bright girl who's going to help. Hi, Amelia.
Hi, Professor. Hi, everyone.
Great. So here's the spacer. Now, it may come in a container like this. It may come apart, right? So that you can clean it. But when you're ready, you're going to put it together and you're all set. It has a mouthpiece that's protected by a cap, so you're going to just whip that off. We have the Flixotide, which she takes every day to prevent asthma symptoms. And then there's the Ventolin, which if she's having symptoms now, something has broken through, then she uses her Ventolin. what's the first thing we're going to do when we're going to use our spacer? We're going to make sure that our metered-dose inhaler is not expired if we haven't used it for a while. So you take it out and you look at the date to make sure that it's still good. We also need to make sure that there's actually medicine in it, because it will shake and spray long after the medicine is finished. So some metered-dose inhalers come with a counter, but if they don't, ask your doctor or pharmacist to tell you how to know when it's empty. So now we're going to go through how you use it. This also has a mouthpiece with a cap, so you have to take it off. Amelia, do you know where this would go? Perfect. Perfect. So now, what we're going to do, shake it, insert it. Now remember, you have to sit up straight, have your head up a little, and then when we're putting this in your mouth, you get a nice seal around the mouthpiece. Then you puff, the medicine comes into the spacer, and you breathe in and out 7 to 10 times. Breathing in and out. Now those breaths don't have to be deep, they don't have to be slow or fast. The beauty of doing it 7 times is that most of the medication will end up in the lung instead of at the back of the throat. And then the parents will be watching that tummy. 1, 2, 3, 4, 5, 6, 7. There we go. So there we go. So the beauty of doing 7 breaths is it doesn't matter if they're slow, fast, deep. As long as you do 7 to 10 breaths, most of the medication is in the child's lungs rather than being at the back of the throat. Now, if your child is younger and won't always breathe in and out through their mouth, we use a spacer with a mask, because once you have that mask having the seal over the nose and the mouth, it doesn't matter whether they breathe through their nose or their mouth, they're still going to get the medication. But what's important is that you get the right size mask. So that's how you use your spacer. And remember, you can watch this video as many times as you want until you're sure you've got it right. And the good news is that your inhalers and the spacer are all available through the National Health Fund. So ask your doctor, your nurse, your pharmacist to give you more information about how you can access them.
Hello, good morning. Good morning. Yes, good morning. And we're off to Okay, good morning, and I'd just like to welcome everyone to the official launch of the Guidelines for Clinical Management of Asthma in Jamaica 2025 here at the Ministry of Health and Wellness's HR Hub, 40, it is on Nutswood Boulevard. I am Giovanni Brady, Senior Public Relations Officer in the Ministry of Health and Wellness, and I'll be taking you through today's proceedings. Good morning again to everybody. We're pleased to host you here at the Ministry of Health and Wellness's HR Hub, as we said earlier, and to welcome those participating virtually via Zoom and watching live through the Jamaica Information Service JIS live stream. Thank you for joining us for this important national milestone. Kindly ensure that your mobile devices are placed on silent. For our virtual participants, please keep microphones muted unless otherwise invited to speak. So we now invite Dr. Camelia Bryan to open today's proceedings with prayer.
Morning, everyone. Can we just stand for prayer? Thank you. All right, let's begin. Heavenly Father, we thank you for bringing us together for this launch of these guidelines. We thank you, Father, for waking us up to see another day. We thank you for all the blessings. We thank you for allowing us to gather today for this meeting. Grant us wisdom, and as we share this information, we see clarity, Lord, and we continue that. We pray whatever our discussions may be today, that we may continue to be impactful to the people that we serve. Continue to guide and protect. In your name we pray. Amen.
All right, thank you, Dr. Bryan. Now, it is my pleasure to formally welcome you to this morning's ceremony. Asthma remains one of the most common chronic respiratory conditions affecting both children and adults in Jamaica. Today's launch marks an important step in strengthening our national response through updated, evidence-based clinical guidance. We're honored to be joined here we're honored to be joined in person and online by Dr. Tamu Davidson, Director, Non-Communicable Diseases and Injury Prevention Unit in the Ministry of Health and Wellness, Professor Trevor Ferguson, Chair, Asthma Guideline Development Group, representatives from PAHO and UNICEF, Regional Health Authority representatives, members of the Asthma Working Group, healthcare professionals, and stakeholders. We thank you all for your continued leadership and partnership. To formally commence this morning's proceedings, I now invite Dr. Tamu Davidson, Director of NCD and Injury Prevention in the Ministry of Health and Wellness. Let her feel welcomed.
Good morning, everyone. Isn't it a fabulous morning? So I would just like to acknowledge the presence of our key partners and just apologize on behalf of PAHO and our Chief Medical Officer of Health and our Director who had to go to another event and competing priority. They really, really wanted to be here this morning for this exciting launch of this particular clinical guidelines. And I'd like to just say, how many persons, whether you're online or here, know someone who has asthma? Let's see a show of hands. Yes. And you may have asthma yourself. So this is very, very important today event for everyone because it touches each and every one in Jamaica. So I'd like to acknowledge the presence again, even though protocol being observed, of Professor Trevor Ferguson, who led the clinical guideline group that would have developed this guideline for the Ministry of Health and Wellness. So, Asthma Guideline Group Development Group, senior colleagues from the Ministry of Health and Wellness, representatives of the regional health authorities, clinicians, nurses, public health practitioners, civil society partners, and all stakeholders joining us in person today and online, welcome. Thank you for being part of this very important milestone. Today marks a significant step forward in Jamaica's response to non-communicable diseases with the introduction of this updated clinical guidelines for asthma in Jamaica in 2025 guideline. So, we would have had established standards, and this is for us a major update on really improving care for persons living with these conditions or have what we call now lived experiences, and those are persons who take care of persons with asthma or an NCD. So asthma remains one of the most common chronic respiratory conditions affecting both adults and children. And so national data indicates that at least 1 in 10 Jamaicans aged 15 years and older live with an asthma-related challenge. So for many, many families, asthma continues to disrupt education, productivity, and quality of life. These realities remind us that asthma is not simply a clinical diagnosis, but is a public health priority. There are faces behind the numbers, and this requires a coordinated, evidence-based, people-centered approach, but also what we call sometimes join-up government or a whole-of-government approach, whole-of-society approach. And as we saw, and perhaps online too, that everyone knows at least someone with asthma. And so it is everybody's business and shared responsibility. The guidelines being introduced today represent more than a technical document. They reflect a shared commitment to strengthening the quality, consistency, and equity of asthma care across our health system. Developed through expert consultation and guided by internationally accepted evidence-based methodologies, these guidelines provide a clear recommendation for diagnosis, treatment, and long-term management tailored to the Jamaican context. They support healthcare workers at every level of care, from primary health centers to hospitals, in making informed clinical decisions that improve patient outcomes. Most importantly, they align with our broader national efforts to reduce the preventable complications, minimize avoidable hospital visits, and empower individuals and families to better manage asthma across the life course. And life course means we say from the womb to the tomb, but from infants right up to our older adults. We don't use elderly anymore, and I think I'm moving towards that category. Many of us in this room and online. So the introduction of these guidelines also supports ministry's broader agenda under the Vision for Health 2030, the primary healthcare renewal policy and framework, and the draft National Strategic and Action Plan for the Prevention and Control of NCDs 2026 to 2036. Asthma control requires more than just medication. It demands integration across prevention, early diagnosis, treatment, rehabilitation, sustained health education. The guidelines, therefore, complement ongoing work in health promotion, school-based interventions, access to essential medicines, treatment services, and partnerships with agencies such as the National Health Fund to improve affordability and continuity of care, and asthma being one of the benefits. So today's engagement also sets the foundation for the stakeholder feedback session that will follow this launch, where your insights of our healthcare team will shape our asthma microplan, which will operationalize our national draft plan. That implementation is realistic, measurable, and responsive to frontline realities. I wish to formally acknowledge the Asthma Guideline Development Group, chaired by Professor Trevor Ferguson. So could we give him a round of applause for their leadership and technical expertise, as I also thank our development partners, PAHO and UNICEF, for their continued collaboration and support in strengthening Jamaica's response to non-communicable diseases, including chronic respiratory conditions. I extend my appreciation to the NCDs and Injury Prevention Unit team, of which I am a part of, and to the wider Health Promotion and Protection branch for coordinating this process and ensuring clinical guideline and guidance translates into meaningful public health action. Today's engagement reflects the ministry's continued commitment to strengthening asthma prevention and control through evidence-based guidelines, partnership, and shared accountability. As we proceed with the program, I encourage each and every one of you to listen carefully, engage constructively, and consider how these guidelines can be translated into consistent, high-quality care across all levels of the health system. The discussion that follows will be an essential part of that process, and your contribution will help to ensure that our national response to asthma remains practical, responsive, and grounded in the realities of service delivery. Thank you, and we're looking forward to your future participation as we work together towards reducing NCDs by a third by 2030 due to asthma and other chronic respiratory diseases. Thank you.
All right, thank you very much, Dr. Tamu Davidson. We now turn to the technical foundation of today's launch. It is my pleasure to invite Professor Trevor Ferguson, Chair of the Asthma Guideline Development Group, to provide an overview of the guidelines for the clinical management of asthma in Jamaica in 2025. Professor, give him a round of applause.
Okay, thank you very much, and good morning, everyone. It's a pleasure to be here. Let me thank the Ministry of Health for providing this opportunity for us to share on the asthma guidelines. Let me also redirect some credit. So while I was the chair for the Guideline Oversight Committee, the chair for the Guideline Development Group is Professor Jennifer Knight Madden, whom you saw in the video earlier on demonstrating with the children. So Professor Knight Madden chaired the Guideline Development Group, but she's unavoidably absent today. So I am, in essence, filling in for her as someone who was part of the team in producing these guidelines. So we do believe that this is an important milestone and are delighted to share with those here, those who are online, and of course with the general public on the guidelines for asthma, and we hope that this will make a significant difference in improving care for people with asthma in Jamaica. So my cameraman is blocking my slides. Thank you very much. So the guidelines, as you would probably have known, were commissioned by the Ministry of Health and Wellness, and the Caribbean Institute of Health Research were the group of persons tasked with producing these guidelines. The guidelines were developed using a specific methodology we call the GRADE methodology. And this GRADE methodology is an approach to a or system for rating the quality of evidence, which offers a transparent and structured process in developing recommendations for guidelines. So in the past, what would have happened that the guideline development process would have been largely opinion-based and expert-based. In this setting, the guidelines remain expert-based, but there's a structured, systematic way in which the evidence is evaluated and the recommendations are presented, taking into consideration the level of evidence that is available. Now, in forming these guidelines, one of the first things is to develop commission a guideline development group. And this guideline development group comprised subject-specific experts, so pulmonologists, for this guideline, we had both pediatric as well as adult pulmonologists, public health specialists, epidemiologists, at least one patient or patient advocate to ensure that the recommendations are relevant to the people that they are intended to treat, and of course a member of the public who would have a broader appreciation of how these guidelines may affect the general population. So in addition to the guideline development group, there's a guideline oversight committee that gave oversight to the guideline development process. So at the end of the day, we would have a high quality product. Now, in terms of the steps involved in developing the guideline, we first worked by gathering and reviewing local and international guidelines and other relevant medical literature, and assess the evidence. We reviewed evidence summaries from previous guidelines or reviewed systematic reviews, judged the quality of the evidence, and then based on a structured framework, then we looked at developing specific recommendations for the treatment of the conditions. When these recommendations were developed, it was then taken to an expert panel in a stakeholder consultation to get feedback and subsequently revised. The revised versions were also sent out for external peer review, and then the final guidelines submitted to the Ministry of Health and Wellness. So as we have seen, this is a very, very important condition. So asthma is a chronic respiratory disease and is characterized by chronic airway inflammation, airway hyperresponsiveness, and reversible airway obstruction. With those pathophysiological mechanisms, it produces respiratory symptoms such as wheeze, cough, shortness of breath, and the chest tightness. And the diagnosis of asthma is made primarily on clinical evidence in terms of the symptoms that the patient presents with, but is also supported by evidence of obstructive pattern and airway hyperresponsiveness on pulmonary function test. With regards to the epidemiology of asthma in Jamaica, and, well, globally as well, asthma is one of the most common chronic non-communicable diseases and affects both in children and adults, and in fact is thought to be the most common non-communicable disease affecting children. With regards to prevalence locally, the Jamaica Asthma and Allergies National Prevalence Study in 2007 found that 19.6% of Jamaican children between the ages of 2 and 17 years had current wheeze, and 16.7% had self-reported doctor-diagnosed asthma. In adults, the prevalence of current asthma was 10.6%, and the prevalence of self-reported doctor-diagnosed asthma in adults was 7.8%. More recent data from the Jamaica Health and Lifestyle Survey 3, conducted in 2016 to 2017, found that the prevalence of presumed asthma diagnosis was 10.6% among men and 11.7% among women. So the guidelines present an approach to the management of asthma and using what is called the asthma management cycle. And essentially it goes through 3 phases, and the writing may be a little bit small, but we'll emphasize the main points. So we start with an evaluation, which is looking at confirming the diagnosis, assessing for the presence of symptoms, etc. And then based on that overall evaluation, then there is modifications made to medications to remove triggers, etc. And then continue to review to see how the patient responds and repeat that cycle. So the entire process should be one of continual improvement where we are evaluating, modifying, reviewing, and the target is to ensure that we have patients who are essentially symptom-free. So the person should be able to live life without wheeze and chest tightness to a large extent. So in terms of making the diagnosis of asthma, what the guideline specifies is that it's best that the diagnosis be made prior to the initiation of therapy, and this is based on the presence of symptoms, findings from pulmonary function tests or spirometry, or the use of the peak expiratory flow rate. The WHO, in their package of essential non-communicable disease interventions, presents an approach to the diagnosis of asthma without the need for spirometry. and essentially recommends that if a patient presents with a history of cough, difficulty breathing, tight chest, and or wheezing, they are likely to have asthma if there are a number of associated symptoms or historical findings. These include previous diagnosis of asthma, history of symptoms since childhood or in early adulthood, history of hay fever, eczema, or allergies, intermittent symptoms with asymptomatic periods in between these symptoms, symptoms that are worse at nights or in the early morning, symptoms that are triggered by respiratory infections, exercise, weather changes, or stress, and symptoms that respond to salbutamol. So based on the clinical presentation, without additional diagnostic testing, you would have at least a high probability of asthma if those symptoms are present. This can be further supported by using the peak exploratory flow meter, which is a fairly simple device and not that expensive. And if there is a demonstration of a 20% improvement in peak flow after the use of salbutamol, that supports the diagnosis. Or an alternative approach is to measure the peak expiratory flow on a number of occasions over a 2-week period. And if there's a greater than 20% variability in the peak expiratory flow rate, then that would support the diagnosis of asthma. And details as to how these are to be done are found in the text of the guidelines. So, of course, today we're only presenting some of the main highlights. We do expect that our clinicians in particular will read the full document so that you'll be able to benefit from the information presented there. Now, with regards to asthma severity, the American Thoracic Society and the European Respiratory Society Task Force recommends that the diagnosis be classified as very mild, mild, moderate, or severe, and this is based on symptoms that are assessed retrospectively after based on the level of treatment that is required to produce control. And I think I'll have to, use this one to see the smaller print. All right, good. So in terms of very mild asthma, this would be defined as asthma that is well controlled with, as required, short-acting beta agonists. Mild asthma would be based on asthma that is well controlled with the use of low-dose inhaled corticosteroids or, as necessary, short-acting beta agonists, or with the use of, as required, inhaled corticosteroids with formoterol. The moderate asthma is defined as asthma that is well controlled with low to moderate dose of inhaled corticosteroids with a long-acting beta agonist and PRN short-acting beta agonist, or with the use of the inhaled corticosteroids with formoterol combination as as maintenance and reliever therapy. So that would be moderate asthma. And then for severe asthma would be based on those who require high-intensity treatment with high-dose inhaled corticosteroids and long-acting beta agonists, plus or minus oral corticosteroids or other treatment modifiers, including the leukotriene receptor antagonists, as well as theophylline or biologic agents. So in essence, we classify our patients as very mild, moderate, or severe based on their responses to treatment. Additionally, the guidelines present the recommendations in terms of specific age groups, and the age groups that are looked at includes preschool for those 1 to 5 years, school-age children for those 6 years to 11 years, adults and adolescents for persons 12 years and older, and following Dr. Davidson for older adults 65 years and older. Now, again, the guidelines also use what is called preferred treatments or alternative treatments. So the preferred treatments are those that are most effective for the management of asthma based on the findings from the Asthma Guideline Development Group and this is usually based on supporting evidence that was reviewed as being strong or a strong panel consensus that the options represented good or best care practices. So we have the preferred treatments, which were ones that we would go for first, and then the alternate treatments if the preferred are not available or there may be other specific circumstances where an alternative is required. And these alternate treatments are those with less effective management options and based on limited evidence available of their efficacy, or because there may be unwanted effects associated with them as well. So the treatment options are identified as preferred or alternative. And then it also defines maintenance therapy, which will be therapy that is used on a daily basis, and as needed or PRN medications that are taken when needed based on the symptoms in order to provide relief. Now, in terms of summarizing the overall pharmacological management for asthma, there are 3 main classes of drugs that are recommended in the guidelines. Of course, there are other agents which would not have been discussed in detail. So inhaled corticosteroids are important cornerstone for management, and the guideline presents, there's a table as well that looks at the comparative dosing for the specific corticosteroids, so that encourage clinicians to go through and become more familiar with that. There are the inhaled beta agonists, which work as bronchodilators or opening up the airways, and these are classified into 3 groups: the short-acting beta agonists, which provide rapid as-needed symptoms. An example of that would include salbutamol. Then there is long-acting beta agonists, which provides long-term bronchodilation and improved lung function, such as salmeterol and formoterol. And then fast-acting beta agonists, which would be a short-acting or long-acting beta agonist with rapid onset of action. Now, if you, there is also a category for maintenance and reliever therapy called MART, and this is a combination of a low-dose inhaled corticosteroids with a fast-acting beta agonist, and this locally would be formoterol, and this is used for both maintenance and reliever symptoms. Additionally, there are the leukotriene receptor antagonists. Montelukast is a primary agent. However, there are some restrictions on this use based on warnings of potential adverse effects, which has been reported through the United States Food and Drug Administration. So in terms of some other key definitions, there is the top-down approach to the management of asthma. And essentially what this says is that treatment should start at the appropriate step that controls symptoms and improve lung function. So you're going to start at a more intensive therapy in order to produce the necessary reduction in symptoms, and this will be based on asthma severity. And then when symptoms improve, then you can step down to a less intensive therapy. And of course, if the patient's symptoms deteriorate over time, then we have to now step up to a more intensive therapy. So additionally, as the guidelines define situations in which patients should be referred to an asthma specialist. And this includes situations where the asthma remains poorly controlled despite appropriate treatment, where the diagnosis of asthma is uncertain, if there's a history of asthma exacerbation, especially that requiring intensive care, if there's frequent or regular use of oral corticosteroids to maintain control. So this suggests that these persons do not have their asthma well controlled and would benefit from specialist care rather than being seen only in primary care. And after follow-up with the specialist, then it is recommended that patients should be seen every 3 to 6 months to ensure that they're being monitored. So you remember that evaluate, modify, and review cycle that we spoke about. So you don't just put the patient on one treatment and leave them on the same thing for years. They should be coming back for review. Now, the next few slides goes through the recommended treatments for the different age groups. And I think I'll spin back around so I can see better again. All right. So this is for preschool children, those ages 1 to 5 years. And again, we start with step 1, step 2, step 3. Step 4 treatment is usually done by the specialist, so it's not specified in the guidelines. So for persons with mild forms of asthma, you would start with step 1, and the usual treatment here would be as required short-acting beta agonists as reliever. The alternative is that you may also add a short course daily inhaled corticosteroids to the as necessary short-acting beta agonist reliever when there is the onset of a respiratory tract infection. So that would be your step 1 treatment. For step 2, the preferred treatment is the use of low-dose inhaled corticosteroids as maintenance and as required short-acting beta agonists. An alternative would be the use of the leukotriene receptor antagonist maintenance with PRN short-acting beta agonists, but there are notes here that this should only be in circumstances where the parents do not want to use inhaled corticosteroids. Step 3 looks at medium-dose inhaled corticosteroids with PRN short-acting beta agonists as reliever. An alternative approach is the use of low-dose inhaled corticosteroids with a leukotriene internal receptor antagonist and as maintenance, and then PRN short-acting beta agonists, or fluticasone salmeterol maintenance and PRN SABA reliever for those in the 4 to 5 year age group. So for our preschool children, those would be our step 1, step 2, and step 3 treatments. And as we said, we have the preferred sets of treatments and the alternatives. For children, school-age children 6 years to 11 years, again, we have step 1, step 2, step 3. Step 4, we would refer to a specialist, and or preferred step 1 treatment would again be as required short-acting beta agonists as reliever for low-risk exacerbation, or concomitant use of as required low-dose inhaled corticosteroids with short-acting beta agonist reliever for high-risk exacerbations. There wasn't an alternate treatment for step 1 in our school age group. For step 2, the recommendation is for low-dose inhaled corticosteroids as maintenance and as required short-acting beta agonists as a reliever. The alternative would be using the leukotriene receptor antagonist as maintenance and as required short-acting beta antagonist as reliever, again with the proviso that the leukotriene receptor antagonist is really for those who would not want to use corticosteroids, or for those who may have poor inhaler techniques despite repeated education. Step 3 would look at medium-dose inhaled corticosteroid maintenance and as required short-acting beta agonists, or inhaled corticosteroids with long-acting beta agonist maintenance with a short-acting beta agonist as the reliever. And again, more severe symptoms are not controlled at step 3 would require a referral to the specialist. For adults and children 12 years and older, the approach here looks at what we call track 1 and track 2 as opposed to the preferred and alternative. And the track 1 for step 1 treatment would be concomitant as required, low-dose inhaled corticosteroids with short-acting beta-agonist as reliever. And step 2, low-dose inhaled corticosteroid maintenance and, as required, short-acting beta-agonist as reliever. An alternative in track 2 would be the use of MART, which is the inhaled corticosteroid formoterol combination used as both maintenance and reliever therapy. For persons not controlled, then we move to step 3, which would be low-dose inhaled corticosteroids with long-acting beta-agonists as maintenance and PRN short-acting beta-agonists as reliever, or a medium-dose inhaled corticosteroid maintenance and PRN short-acting beta-agonists, or low-dose MART therapy as if they are following that track. Again, if persons are not controlled with these interventions, then we should refer to a respiratory specialist. So those summarize the overall approach to treatment. Just to finish up, we have some general guidelines for patients as well as for physicians. And so in terms of the general guidelines for patients, the guideline recommends that all patients with asthma or their parents should keep the following under consideration. So each patient should have an asthma action plan to assist in the personal management of asthma. We'll illustrate the asthma management plan in a couple slides. Each patient should be aware of and avoid all possible triggers of asthma, should ensure regular follow-ups are held with their primary care doctor. Patients as well as guardians of children should ensure that the short-acting beta-agonist is not overused. And overuse really suggests that if they're using the short-acting beta-agonist more than 2 days per week, or if a canister is completed in less than 4 months. Also, patients as well as parents and guardians should ensure that they rinse the mouth after the use of the steroid metered dose inhaler or the dry powder. And of course, that's done without swallowing. And in cases of emergency, all patients should immediately be taken to an appropriate healthcare facility. So don't try to manage asthma exacerbations at home. That's a very, very important point. I think many people try to do that. For the healthcare worker, clinicians should evaluate the risk of exacerbations of asthma and for asthma control in patients. Also, where possible, they should use direct observation to evaluate the patient's techniques in using devices to ensure that there's adequate delivery of the medication to the patient. Clinicians should also advise patients that medications that are to be taken twice daily should be taken approximately 12 hours apart. Important as well, inhaled corticosteroid is the recommended approach for short-acting beta-agonists, and liquid salbutamol is not recommended. Clinicians should ensure that patients know that the PRN SABA, the short-acting beta-agonist, should be delivered through a metered dose inhaler or with a spacer, and of course for the younger children that has face mask be used, and that may also be important for the elderly. Clinicians should also note that in general a valved chamber is considered superior to other spacers, and that clinicians and healthcare workers should inform patients about the appropriate use of short-acting beta-agonists to reduce the excessive use. And we described that in terms of what excessive use was earlier. It's important to monitor growth in children using height percentiles because there may be some association with steroid therapy and impairments in growth. And of course, where there are indications for step-up in treatment, the patients with uncontrolled asthma should step up to either the preferred or alternate treatment, and patients should be recommended to the next step. So we ensure that we're stepping up if the control is not being achieved. So this last slide really looks at the asthma action plan, and each patient working with their caregiver should ensure that they know which medication should be taken when they are stable, what to do if symptoms develop, and of course the red zone if there are significant symptoms that they visit the emergency room immediately. And this is provided in the guidelines so that persons can go through this and have a better understanding. So to acknowledge that some of these slides were prepared by Dr. Jacqueline Duncan and Professor Knight-Mann, so thanks to them both, and to acknowledge the full list of authors and the Guideline Development Group, as well as the Guideline Oversight Committee, the Ministry of Health and Wellness, and their coordinators that supervised and supported the process, or external peer reviewers and other contributors. So thank you all very much.
All right, so thank you again, Dr. Ferguson. As you guys can see and as you'd have heard, there's a lot of research and resources and a lot of different stakeholders that would have been involved in the, bringing together of this process, and it kind of underscores something that we always talk about in the ministry, the partnerships. It's very important that we have partnerships because that's the only way we can forge a pathway towards health. Thank you again, Mr. Ferguson. I now want to invite clinical excellence must always be anchored in lived experiences. And I want to invite Stephanie Bernard for a presentation. Give her a round of applause.
Good morning, everyone. I know it's not Jamaica Day, it's Valentine's Day, but I was at an event that called for the Jamaica's color with a touch of red. And so I am a Jamaican girl through and through. This morning, I am here just to do a poem on asthma. When Dr. Davison asked me, I was very keen to do so because I do have persons that I know. I have an adopted nephew, and he spent a lot of time in the hospital due to asthma. Just the other day, one of my neighbors, they actually died from asthma. And so this morning, I penned a poem. It is called Measured in Breaths. Have you ever felt like you can't breathe? Like the air has turned against you? Like death brushes past your cheeks? Not to take you, just to remind you it could. Lungs tightening, airways narrowing, each breath no longer automatic, but a conscious, desperate act, measured, counted, fought for. Have you ever had to be cautious of where you go, scanning rooms before you enter, reading the air like a warning sign, perfume too heavy, smoke too close, chemicals lingering where laughter once lived? One careless whiff, one unseen trigger, and suddenly your life balances on a hedge of a breath. Have you ever known the panic of silence when your chest screams but no sound comes out, when oxygen becomes a privilege instead of a promise? Your heart races ahead of you, fear pounding louder than your pulse, while the world keeps moving, unaware that you are fighting just to stay present in it. Have you ever lived with the constant caution, planning exit before arrivals, carrying medicine like an armor, learning your limits earlier than anyone should? Asthma is a burden borne by many, shaping lives and changing course, measured breaths and careful steps, strength learned in every pause. Asthma is not a weakness. It is endurance, vigilance, and restraint. It is learning to survive in a body that sometimes forgets to do so. It is courage measured in breaths, strength hidden behind inhalers, and resilience found every single time you breathe again. Thank you.
Okay, thank you for that powerful and meaningful contribution. You said that today is Valentine's Day, but you're green and black and gold. No, man. But as I'm saying, your color symbolizes your love for Jamaica, so it's still Valentine's Day regardless. All right, ladies and gentlemen, we now arrive at the highlight of this morning's program, the official launch of the symbolic handover of the guidelines for clinical management of asthma in Jamaica 2025. To our viewers online and those watching via JIS live stream, thank you for remaining with us as we mark this important national milestone. So at this time, I want to invite to the stage Dr. Tamu Davidson and Professor Trevor Ferguson. We also recognize our development partners and members of the Asthma Working Group for their contribution to this process. All right, photographers, everyone's ready? Everyone's ready? All right. All right, ladies and gentlemen, on the count of 3, we will proceed with the unveiling. Let me just ensure that Dr. Davidson and Professor Ferguson are in the correct position. All right, photographers ready? Videographer ready? See, the videographer still panning his camera. All right, looks like he's ready now. All right, so after 3, 1, 2, 3. Woo. Round of applause. All right, let us acknowledge this significant step forward in strengthening asthma management in Jamaica with just a few photos. So we'll allow. She's present. Okay, and I'm being told Dr. Davidson has a few more words, to mark this special occasion.
Thank you. So now that we have unveiled this guideline, the importance is that the effectiveness of this particular clinical guideline is not to be on a shelf, dust to be gathered, but it is a publication that should be used. So it is our collective responsibility now to ensure that the guidelines are disseminated. So I'm going to charge everyone who is here in this room, anyone who is online, anyone who will watch this recording, anyone who will see anything on social media, tell one, share. The guidelines are available on our website, so you can download. So please share with one other person, whether it's someone who is another healthcare worker, whether it's someone who has been affected, someone who is what we call lived experience, so the caregivers. Share it with someone else so that they can also share it with other people. And I'm going to encourage those persons living with asthma to also, really get to know what the guidelines are. And when you go to your healthcare provider, you also should ask them questions and ask them about your own care, because it is a partnership. So let's ensure that this guideline, the standard, is applied right throughout the health system. So we move not only from just a policy, but a policy that's practical, that's in use, that's active. It is a living document. And so, therefore, it's my honor that we have unveiled this. We have launched this today. Again, I know our senior executive staff leaders and staff within the Ministry of Health wanted to be here today. So on behalf of them, I'm imploring you to ensure that this is disseminated and shared. So may this document continue to strengthen clinical practice, which is evidence-based, the highest standard of quality of care for our people in Jamaica, support our healthcare workers in being able to make that decision and contribute better to asthma care. And so we expect to see an improved quality of care for all people in Jamaica, and especially those who have living experience of living with asthma. So thank you, everyone. And let's a round of applause again. This is really big for us in this updated clinical care guideline.
All right, thank you again, Dr. Davidson. We now move to the symbolic handing over. This handing over represents our collective responsibility to ensure these guidelines are implemented across all levels of the Jamaican health system. I invite Dr. Tamu Davidson again to present copies to our partners and regional representatives. So we have 2 copies here, one for Professor Ferguson. Round of applause. And if we have any representatives here from the Southeast Regional Health Authority, just come in queue. So you can get your photo moment as well with the symbolic document. Makeup, is makeup here? Again, touch her up a bit.
And I'm going to invite our doctor, we have a nurse practitioner, we have a public health nurse. So I'm going to ask all 3 persons, and we have a panel here as well.
Okay.
So I'm going to ask for...
We have a full house.
Yes, I just want to remind us that this is not just one category of healthcare worker or health professional, but it's a team. So we have here, we're going to do just the symbolic handover to Southeast Region here and their representatives. So we have a physician and public health specialist. We have our family nurse practitioner. We have our public health nurse representing nursing group, and we have a planner here. Thank you.
All right, round of applause again. To our viewers online, this handover represents a national commitment that extends beyond this room. Ladies and gentlemen, as we conclude this morning's ceremony, today's launch represents not simply the publication of a document, but a strengthened commitment to evidence-based asthma care across Jamaica. On behalf of the Ministry of Health and Wellness, I extend sincere appreciation to our leadership, our technical experts, our development partners, the Asthma Working Group, the Jamaica Information Service, and all stakeholders present and online. And it would appear we have one more handing over. Okay, so I'm going to invite Professor Ferguson again to come on stage on the platform.
So this is just a small token of our appreciation for your presentation today. We work very hard to ensure that it reflects our lifestyle, healthy lifestyle basket. Yes. And so thank you again for your presentation on behalf of the Guideline Development Group, and certainly Professor Nightman, who led this charge and who was unable to be here, but I know she's listening online. Thank you.
Okay, we thank you all for your continued collaboration and thank you for your presence here today. This concludes the official launch ceremony. Please join us for coffee and light refreshments outside, in that corner over there, or coffee corner over there. For members of the media, interview opportunities will follow shortly. Thank you and have a productive rest of day.